So welcome everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, COVID, RSV, and flu, oh my, preparing for the upcoming respiratory virus season, featuring Dr. Molly Fleece from the University of Alabama at Birmingham. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC, or you can also email us at arcipc@uab.edu. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, and the Region 4 Public Health Training Center. You can learn more about these organizations and their centers as a whole at their websites listed on the screen. We'd also like to let you know about our next upcoming webinar with Dr. Katrine Wallace, Pandemics, Infodemics, and Information Overload, How Consistent, Clear Communication Can Help in Future Outbreaks. An infodemic is defined by the WHO as too much information, including false or misleading information in digital and physical environments during a disease outbreak. During the COVID-19 pandemic, a bolus of conflicting information, data, and opinions about the virus and its prevention measures led to public bewilderment and message fatigue. In this presentation, Dr. Katrine Wallace from the University of Illinois at Chicago's School of Public Health will review the problem of infodemics and how we can reduce information overload and confusion by prioritizing consistent and clear science communication. This webinar is also presented by the ARC-IPC and co-sponsored by the Region 4 Public Health Training Center. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must, 1, register for the training, 2, watch the entire program, 3, complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on October 25th, 2024. If you experience any issues, please email arcipc@uab.edu. And finally, it's my pleasure to introduce our speaker. Dr. Molly Fleece is an assistant professor in the UAB Division of Infectious Diseases and an associate healthcare epidemiologist for the UAB Health System. Dr. Fleece completed her medical degree at the University of South Alabama College of Medicine. She then completed her internal medicine residency and infectious diseases fellowship training at the University of Virginia. She is a clinician, educator with interest in general infectious diseases, antimicrobial resistance, hospital-acquired infections, and infection prevention. Thank you, Dr. Fleece, for being here. I'm now going to hand things over to you.
Thank you so much for having me today. So I am thrilled to be here to talk about COVID, RSV, and flu, oh my. And I've edited this after last week because of a dearth of information that's come out in this past week. So no longer are we preparing for the upcoming respiratory virus season, but it is here. And I have no financial disclosures. My only disclosure is that I hope for the health and wellness of everyone for this respiratory viral season and beyond. And so my objectives today are to review current data and projections for all COVID, RSV, and influenza circulation for this upcoming season, how to look and where to look for what's going on in the community in order to help different facilities prepare for this season, thinking about policies and procedures to limit transmission of seasonal illnesses like these viral illnesses, including updates on vaccinations for both staff and residents, a lot of hot off the press information even over this last week, as well as strategies on how to contain respiratory outbreaks if they are to occur in different healthcare facilities. So first, to look at the current data and projections of these respiratory pathogens. So flu, RSV, and COVID all result in many thousands of hospitalizations each year, and it's not known exactly when or how severe the impact of these will be known. Last year, we faced what we called a triple-demic for all three of these, and our hope is that this year we will be better prepared with a few different mitigation strategies in place to where that triple-demic does not occur. We also know that restrictions that were put in place during the peak of the COVID pandemic really altered the seasonal patterns of these different viruses. Last winter, the flu peaked in December instead of February like it normally does. COVID, on the other hand, stayed steady with infections and deaths occurring throughout the season with a peak in January. And then RSV peaked several weeks earlier last year, but it also circulated longer than usual. So some stark differences in the past couple of years. What we do know is that all of these pose a major threat to particularly older adults, older immune compromised adults, as well as young children, but that does not exclude the healthy individuals too. RSV is probably the least familiar of these three viruses that we've talked about in the last couple of years. It's increasingly recognized as a major threat, and it has a similar burden to influenza, so just generally bad. So it's important for all of us to understand the burden of disease, the severity of each, how to protect ourselves and our patients and our loved ones as we go into this season. So thinking about COVID-19 and updates for the US, where we currently are. So this is from the CDC's website, looking at early indicators of disease transmission, thinking about test positivity and how many emergency department visits there are for COVID-19. And you can see for both of those, we have had a decrease in the most recent week, as well as a decrease in one of our severity indicators, that being hospitalizations. We have seen an increase in the percentage of deaths in this most recent week. And again, important to remember that this is a lag variable after recent increases in hospitalizations from weeks prior. Also thinking about COVID and looking at different variants that are circulating. We know through the COVID data tracker and the CDC that we are monitoring SARS-CoV-2 viruses from the different lineages. And this is only looking at lineages whose weighted estimates are above the 1% threshold. So in the past few weeks, you may have heard many people talking about the XBB.1.5 or one of the Omicron group variants being predominant. And now what we're seeing more is this EG5 variant, also very highly transmissible, effective at evading the immune system and resulting in increased hospitalizations. And as we go through this respiratory season, we will need to keep an eye on these variants as well as any others that crop up. Thinking more about outpatient visits for respiratory illnesses, this is looking at the outpatient influenza-like illness surveillance network, so a metric that encompasses illnesses due to influenza, COVID, RSV, and other respiratory viruses that are circulating in the community. More of syndromic data that's helpful to interpret in the context of other sources of surveillance data for specific respiratory viruses. Again, influenza-like illness being fever and cough and or sore throat. And you can see where we are this year in that very short truncated red line at the front of this chart compared to the yellow mustard colored line. So we are starting well below where we were this time last year. So during week 41, 2.3% of all patient visits reported through this network were due to respiratory illnesses, including ILI. It has been stable over the last week or so, and we remain below that dotted line baseline of 2.9%. So hopefully that means coming into this season, maybe we're looking at more of a mild season, but we will see how things go along. Additionally, another metric that the CDC and others use looking at mortality from both pneumonia, influenza, and COVID. This is a graphic that shows influenza deaths along the bottom in the yellow blips. The blue is COVID deaths. The red line are the percentage of deaths due to all of those variables, with that undulating baseline and epidemic threshold along the bottom. So you can see how deaths from COVID compared to deaths from influenza in the past, and how we remain above our epidemic threshold. This may be the last year that we see this type of data presented this way, mainly because of influenza, not being able to fully capture our influenza deaths appropriately here. And we also know that our seasonal influenza deaths are likely higher than previous estimates. So more to come on this, but I think we will be able to see different graphics for all of these respiratory viruses in the near future. So how are we doing in terms of influenza? So this is looking at positive tests reported to the CDC by all clinical laboratories through the week of October 14th. So we're looking at about a 6.5% positivity rate, and you can see more circulating influenza A than B subtypes. In terms of the country as a whole, Alabama is in the minimal category at this point, but you can see where our neighbors are starting to creep up in terms of activity level for ILI into the low category. And then moving on to our third respiratory virus that we'll be talking about. This was a Health Alert Network CDC Health Advisory that was released a few weeks ago, looking at the increase of RSV, or respiratory syncytial virus activity throughout the southeastern United States. So historically, reached the beginning of it, starting more in the north and the west, and then migrating down south over the next couple of months. And this pattern may suggest a continued shift back toward more seasonal RSV trends, as we observed traditionally prior to the COVID pandemic. As part of this CDC Health Advisory, you can see on this graphic here, looking at percent positive testing for RSV in the United States. And you can see about the time that Health Advisory Network alert was issued, you could see a change in the direction of the lines on this graph increasing. And I think we anticipate these to continue to increase over what we think will be more of a normal RSV season. And then lastly, what are we seeing in Alabama? This is looking at viral respiratory disease emergency room visits for both COVID, influenza-like illness, and RSV. And you can see that we are seeing an increase in both ILI and RSV visits in our ERs, whereas we are seeing a continued maybe plateau of where our COVID numbers had been over the last several weeks. So now that we know where to look for this data and what our data looks like in our area as well as nationwide, we certainly know that these viruses are circulating. So we are in the beginning of this respiratory season. So now to review some policies and procedures on how to limit transmission of these seasonal illnesses, including many updates on vaccinations. So all of these are respiratory viruses. So replication of this virus occurs within the respiratory epithelium and then subsequent destruction of those cells, resulting in the ability to spread person to person via large droplets, as well as with aerosolized droplets that we'll talk about in a few minutes, through mechanisms that we are all familiar with: coughing, sneezing, as well as direct and indirect contact with secretions, thinking about contaminated surfaces, and then touching eyes, nose, and mouth, and or fomites. What helps guide transmissibility as well as transmission of these respiratory viruses includes various factors. So the virus itself, environmental and host factors all influence whether a successful transmission occurs by governing not only the infectivity of that respiratory virus, as well as the contagiousness of the infected person, the environmental stress on the virus, which affects its ability to persist and survive during that transmission period, and then the susceptibility of the person who has been exposed. So certainly not a simple mechanism at all. And again, these are spread via respiratory droplets. And throughout COVID, I think we all have heard more about droplets and aerosols than I think we ever maybe wanted to know about. But we know now more about this spectrum, or the spectrum of size, that governs the difference between a droplet and an aerosol. And this helps to guide how these viruses are transmitted, whether through short-range transmission or more long-range transmission. So thinking about more short-range transmission, you have an infected individual. And so here on this graphic, that person is in red, and they may shed this virus in an exhaled breath droplet and or aerosol, contaminating their immediate bodily surface, like their skin or their clothes, or the surrounding objects and surfaces like tables or other fomites like the cell phone in this picture. If the susceptible person is near them, so in this graphic, this person is in gray, if they breathe in virus-laden droplets or aerosols, or come into direct contact, then they can become infected. And then if you have someone at a distance, but you have long-range transmission through virus-laden aerosols, then they too can become sick. So thinking about this as more of a spectrum of size of droplets to aerosol, and then how all of the other environmental conditions may contribute or hinder this process from occurring. So now that we've reviewed how these respiratory viruses are transmitted, so how do we reduce that transmission? So transmission-based precautions are a big emphasis, certainly in healthcare facilities, as well as in the press. And we do this through first and foremost, standard precautions. So what we all do based on the assumption that any patient may be colonized or infected with organisms that are transmissible. And we do this with all patients, right? In addition to the need for any specific transmission-based precautions based on the particular pathogen that we may be worried about. This includes consistent and constant use of hand washing, as well as PPE, for thinking about contact with bodily fluids, blood, mucous membranes, or non-intact skin. So this is the basis for all that we do when we think about transmission-based precautions. And I would be remiss in this talk without discussing hand hygiene. And that's because we all in healthcare have frequent encounters with patients. And so all of these encounters, if we're not practicing strict hand hygiene, could potentially put our patients at risk, ourselves at risk, and then anyone else that we may come in contact with. And so in general, the first and foremost important infection prevention tenet is adequate hand hygiene, with that goal to be reducing healthcare-associated infections and transmission of pathogens. And so this graphic comes from the evidence-based model for hand transmission during patient care and the role of improved practices, published in The Lancet in 2006, showing that patient-to-patient transmission of pathogens via healthcare personnel hands require 5 sequential steps. So with any process that entails several steps, there are several opportunities to break this cycle of transmissibility with proper hand hygiene techniques. And then that brings me to the WHO guidelines on hand disinfection, or the 5 moments for hand hygiene, where all healthcare personnel should remember these for every patient encounter. So thinking about other transmission-based precautions, so now that we are all experts again on standard precautions, thinking about other ones, contact precautions being very important for a few of these respiratory pathogens, whereas we strive for private rooms for our patients and really limiting patient movement throughout the healthcare facility, and then utilizing gowns and gloves as shown in this picture. Reinforcing the need to clean frequently touched surfaces, and then utilizing dedicated equipment that can stay with the patient and within the patient room if possible. To go along with contact precautions, we also can review droplet precautions. Similarly, a private room where we limit patient movement, but here we are utilizing surgical or procedural masks to try and reduce the spread of potential infectious droplets and aerosols. I like to reference Appendix A from the CDC Guideline for Isolation Precautions, Preventing Transmission of Infectious Agents in Healthcare Settings. I think it's a really great reference for all of us to have in our back pockets, and I'm sure most of us, if not all, are familiar with this. They divide these isolation precautions up by pathogen as well as by syndromes. And so here I'm showing you for respiratory infections, syndromic empiric precautions where contact and droplet precautions are recommended. And then droplet precautions potentially can be discontinued when adenovirus and influenza have been ruled out. So you may be reading this and saying, well, what about COVID? And we'll talk about COVID in a minute. But notably, respiratory syncytial virus, RSV, is on here as needing contact precautions. And that may be a little surprising that droplet precautions are not necessitated in this document. And so although RSV may be transmitted via droplets, direct contact with those infected respiratory secretions is really the most important determinant of transmission, and consistent adherence to those contact precautions, in addition to standard precautions, really does prevent the transmission of RSV throughout healthcare settings. So even though droplet is not explicitly named here, protection of the eyes, nose, and mouth by using a mask and/or eye protection or a face shield is important when you are worried about a spray or a splash or any respiratory secretions. That would be more defined as standard precautions. So just like with the other precautions we talked about, patients with RSV should also be placed in single rooms, or in the setting of an outbreak or a cluster, they can be cohorted together as well. And so thinking about type and duration of precautions in a healthcare facility. So what type of precautions are needed and for how long? So for influenza, we're thinking about standard and droplet precautions, and droplet precautions should be implemented for patients with suspected or confirmed influenza. And they should stay in place for at least 7 days after illness onset, or until 24 hours after resolution of fever and respiratory symptoms, whichever is longer. Now with RSV, we're looking at standard plus contact precautions, and then these should be in place for the duration of the illness. And then for COVID, we're looking at standard precautions plus an N95 respirator, gown, gloves, and eye protection. And then for duration of how long transmission-based precautions should be in place, I put it varies, and it varies dependent on the severity of illness and the underlying immune system and/or degree of immune compromise of the patient. So I kept it simple and left it as it varies. So how do we stop the spread of these respiratory viruses? So we've talked a lot about hand hygiene. I think we are all very familiar with respiratory hygiene and respiratory etiquette after the COVID pandemic teachings that we have all been through. We all are familiar with masks as a method of source control to try and prevent the spread. But I wanted to focus a little bit more on the concept of staying home if sick, and this concept of avoiding presenteeism, as well as focusing on vaccinations with all of the updates that we have had in the last few weeks. So the challenge of healthcare workers' presenteeism. This is really important for us to start thinking about with all of these circulating viruses in our community. And we know that healthcare worker presenteeism is very common, and there are many reasons for this. There are simply the logistical challenges of staffing. It's difficult to find sick relief. There are financial considerations, clinical schedules that make not coming to work difficult. Unfortunately, there's a social norm where it's may be deemed unprofessional to take a sick day, and worries about lost productivity, as well as potentially the "I'm not that sick" mentality. There have been many surveys looking at this topic, and in this one in particular, being an online survey of healthcare workers who experienced influenza-like illness symptoms, 50 to 90% of those who were surveyed reported that they've worked or would come to work when experiencing symptoms of infection. And this is, again, looking at over 500 respondents from over 50 countries. And again, looking at whether they would work with a fever, about a third said yes, and over 90% said they would work with mild symptoms. So really important for all of us to remember that this places our patients and other colleagues at risk, and also contributes to outbreaks within healthcare facilities, and something that we have direct control over preventing during these respiratory virus seasons. So here are just some examples of outbreaks that have occurred within healthcare facilities where sick healthcare workers were identified as the primary source or implicated in transmission. And these are not, small outbreaks, and they all have significant consequences. So just as a reminder to all of us, to not feel the need to show up if we are not feeling at our best, and that it is advised to stay home if you were feeling sick. So I will spend some more time talking about vaccinations, and these have some hot off the press just within the last week or so updates. And in seasons past, when I first started talking about respiratory viruses, I spent all of my time talking about the flu vaccine. In the past couple of years, I have added the COVID vaccine, so then there are 2, and this will be the first year that I get to talk about 3, which is just wonderful. And so here is a nice summary that I found looking at vaccines this fall for influenza, COVID, as well as RSV. And so I'll talk about all of these in a little bit more detail, but just in terms of what is new, we now have some differences with our COVID vaccinations, and we have a new 3rd vaccine that was just approved, and then this whole new section of RSV at the bottom, which is just very exciting. And this is also really important for us to talk as healthcare workers because of vaccine hesitancy. And so this is a survey in this year looking at attitudes about influenza, COVID, and RSV virus and pneumococcal disease, and looking at healthcare worker and U.S. adult thoughts and feelings about getting vaccinated. And so while it was encouraging to see that 65% of all U.S. adults agree that the flu vaccine is the best way to prevent flu-related hospitalizations and deaths, less than half say they do not plan or are unsure if they are going to get vaccinated this year. So I think a lot of opportunity for ourselves to educate ourselves, as well as to have conversations with our patients, as well as our friends in the community. So for influenza vaccination, this is recommended for all residents and healthcare providers in long-term care facilities, nursing homes, hospitals, everybody. So we do this to save lives, and we do this for everyone over the age of 6 months of age, with really very few exceptions. So anyone younger than 6 months of age is not recommended for. And then anyone with a severe life-threatening allergy to an ingredient in the flu vaccine, not egg, but another ingredient in the flu vaccine. Or if you have had a severe allergic reaction to the influenza vaccine in the past, you could be excluded. There are some precautions that can be considered, like a history of Guillain-Barré syndrome within 6 weeks of an influenza vaccine in the past. But in general, those can be discussed with healthcare providers on an individual basis. In terms of when, now would be great. So ideally by the end of October, but you can truly receive this vaccine so long as there are influenza viruses circulating in the community. And it takes about 2 weeks after vaccination to develop antibodies against the flu. So if anyone out there has not yet had the time to go get your influenza vaccine, I highly recommend doing it after this talk. And so what I hear most frequently about the flu vaccine every year when I'm counseling my patients is, oh, I have received the flu vaccine in the past, and then I got the flu, so it didn't do its job. And I think in the past, we've talked a lot about vaccine effectiveness, and it truly does vary season to season. But I will highlight more of the benefits to getting vaccination outside of just it kept me from getting sick. So thinking about seasonal flu vaccine effectiveness, this is looking back all the way to 2009. And so you can see how each year varies quite drastically. The 2020 to 21 vaccine effectiveness bar is notably absent here, and it truly wasn't estimated because of how low and how infrequently the flu virus was circulating during that season, predominantly due to all of our other mitigation strategies for the COVID pandemic. And so there are two big factors that play an important role in determining the likelihood that vaccination will protect a person from the flu illness. One is the characteristic of the person getting vaccinated, like their underlying medical conditions, general health, and age. And then two is this question about how well does the vaccine match the flu viruses that are circulating in the community. And this depends a lot on how the vaccines are made and the surveillance of the circulating vaccine in the Southern Hemisphere, and how we can try and predict whether those circulating flu viruses are going to be the same as what we see here in the Northern Hemisphere. And so you can see up at the top, I have listed on a season when the antigenic match of the vaccine did not quite match the circulating strains very well. The vaccine effectiveness was fairly low at 10%, but in seasons where it matches very well, our effectiveness is quite high. And last year was one of those seasons where the effectiveness was about 54%. I just saw a news article this morning while I was refreshing these slides where the first estimates about the vaccine effectiveness for this year have been made or postulated based on what is circulating in the Southern Hemisphere. And the hope is that the match will be quite good this year. So more to come. But I think it's also very important not only to talk about how well does the vaccine match the circulating strains, but also to highlight how important these vaccines are at saving lives, at reducing severity of illness in people who are vaccinated but still get sick, how it truly keeps children out of the ICU, keeps children from dying and other life-threatening conditions, reduces the risk of long-term complications in all comers, including our very young and our very old, like lower rates of cardiac events and worsening of chronic lung disease, and then how it protects some of our most vulnerable, including pregnant people and young children. So not only do vaccinations in pregnant people truly save their lives, but also offers robust protection to their infants in their first few months of life when they otherwise would not be able to get the vaccine. So very important to protect your loved ones, as well as those who may be more vulnerable to the severe complications of influenza. Now, another update for this year is, well, what about an egg allergy? And so this was updated in this most recent guidance, where egg allergy necessitates no additional safety measures for influenza vaccination beyond those recommended for any recipient of any vaccine, regardless of the severity of previous reaction to egg. And so the CDC notes that severe and life-threatening reactions to vaccines can occur in any vaccine in any case, regardless of allergy history. So important to always get these vaccinations in a place where an acute hypersensitivity reaction can be treated promptly, but no additional safety measures are needed. And all people with egg allergies should be able to get the vaccine safely. Now, which influenza vaccines are available for this season? This chart was also updated here recently, and you can see on the right-hand side where the strain for the Victoria A like virus was updated this year. And that's compared to the 2022-2023 US flu vaccine composition. And whereas most of these are injection, at the very bottom under table 2, you can see the recommendations for those who may prefer intranasal. And then one of the reasons why I spend so much time talking about influenza vaccination is that we as healthcare providers truly have a very important role in preventing the transmission of influenza in our healthcare facilities. And this is one of my favorite graphics from a paper from 2019 in Open Forum of Infectious Diseases, looking at healthcare provider influenza vaccination and how it can decrease patient mortality. So there's not much that we ourselves can do just by coming to work to decrease patient mortality other than caring for patients, but simply by us getting vaccinated, there is a strong signal that in long-term care facilities, patient mortality is decreased when healthcare providers are vaccinated. Not only that, it reduces healthcare provider illness, reduces nosocomial influenza-like illness and outbreaks, certainly, reduces absenteeism of healthcare personnel, and decreases healthcare costs. So a really important thing that we can do for all of our patients. And then looking at trends of influenza and COVID vaccination coverage among healthcare personnel. And so thinking about flu vaccines, since the beginning of the 21st century, there has been some significant changes in how influenza vaccinations are viewed in healthcare. So in the very beginning, flu vaccines were merely encouraged by vaccine champions, government agencies, professional societies, but vaccine rate uptake among healthcare personnel remained very low at less than 50%. Since then, it became an employee health benefit to get the vaccines, and now it's moved to more facilities mandating a flu vaccine. And with that, we have seen increase in influenza vaccine uptake, as well as reduced incidence of ILI, missed days work, healthcare costs, and like I said, patient mortality. So what we saw was voluntary influenza immunizations led to low rates of uptake and nosocomial outbreaks. But since policies were in place to increase number of healthcare facilities requiring flu vaccine, all healthcare facilities have rates now greater than 90%. And I think that is just wonderful. So with the Advisory Committee on Immunization Practices, or the ACIP, and the CDC certainly recommends that all healthcare personnel receive our annual influenza vaccination, as well as what is now going to likely be an annual COVID vaccination as well. So whereas we do not have the nationwide COVID vaccine mandate in place anymore, as we did during the COVID pandemic, I think it'll be very important for healthcare facilities and employee health and occupational health to truly encourage and discuss with their employees how to protect themselves and their patients with the COVID vaccine. Thinking not only about healthcare personnel, but also residents within our long-term care facilities, it's important to think about how to vaccinate our residents. And so this was a paper in the MMWR published very recently, looking at disparities in COVID vaccination status among long-term care facility residents. And what was found was this vaccination status was lowest among residents in facilities in the HHS Region 4, which is where Alabama is located. So a little less than, or about a third of all residents potentially in our area are vaccinated. This study found that the rates were lowest among Black or African Americans at about 40%, as well as multiracial at about 42% of long-term care facility residents. And that up-to-date coverage increased with age. So whereas almost half of our residents over the age of 75 were up to date, only about a third of our residents in that 30 to 50-year-old range were up to date in their vaccinations. Women also tended to be more up to date with their vaccinations than men. So key opportunities here, not only when we're thinking about how we can ensure that all of our healthcare personnel are vaccinated, but which of our residents may not be vaccinated. Also, some updates in our COVID vaccines offered this season. And so this is looking at the 2023 to 2024 formula for persons over the age of 6 months. And I've really just snipped out the 12 years and older because I thought that would be the more important or more relevant section for this group. And really some other changes, how we talk about COVID vaccines. So trying to change the lingo, no longer referring to a primary series and boosters, but trying to steer the public and the dialogue towards the idea of potentially a single annual immunization with the latest version of the vaccine titled updated vaccines. So whereas in the past, boosters were there to boost our existing immunity from a prior vaccination or infection, these updated vaccines are expected to provide protection against circulating variants, helping to build a truly new response to those variants. So here we have two mRNA vaccines that we have heard quite a lot about that have been reformulated for this year, the Moderna and the Pfizer, as well as a new kid on the block, the Novavax, which is a protein subunit vaccine, which has been authorized and approved for adults 12 years and older. I'm thinking again about these vaccines, so targets more of a variant of the Omicron, this XBB.1.5, as well as its cousin down here, this EG.5 that I mentioned on the first slide. And so, whereas it's impossible to truly match each new vaccine with these variants because of the speed and the rapidity that these variants that are circulating change and evolve, but what we do know is the, history of these variants and how closely related these are. So whereas the current vaccines may not provide protection identically to the current circulating strain, they're pretty darn close. And so we feel confident that there's going to be protection with these updated vaccines. So the question always comes up about co-administration. And so do we recommend that influenza and COVID vaccines are co-administered? I have a title of a study from Israel looking at just that same question. And it was deemed that co-administration was safe and effective, and it did not affect protection by getting the two vaccines at the same time, nor did it result in worsening of the side effects compared to getting either of them alone. So yes, you can get them both at the same time. So switching gears a little bit to talk about RSV, this was a large study in the MMWR also from the beginning of this month, really highlighting the severity of RSV infections and looking at RSV in light of COVID and influenza and how we judge severity of infection. So those needing additional oxygen therapy in a hospital, non-invasive ventilation, ICU admission, mechanical ventilation, and/or death. And so what you can see here is that while fewer people were hospitalized with RSV as compared to COVID or influenza, the baseline characteristics of these patients were very similar. Most of them, or the median age, was in the early 70s, and all of them almost had chronic medical conditions. And we see similar severe illness and adverse outcomes with RSV that are similar, if not worse, than that of COVID and influenza in the current era. So really important to highlight why vaccines are so exciting in the realm of RSV, because we hope to prevent many of these adverse outcomes in our more vulnerable populations. And that more vulnerable population are our older adults with chronic medical conditions that are very common in our region, as well as other factors associated with increased risk for severe disease. And on here, you can see residents in a nursing home or other long-term care facility, as well as frailty, advanced age, and then anything else that we as healthcare providers may determine to increase the risk of severe disease. So not every factor can be considered on this chart. But we have new immunizations to protect against severe RSV. And so we have vaccines now for adults 60 and older, as well as what I'm not going to spend any time talking about here, but happy to try and answer some questions in our babies. So we have some new options for RSV antibody to be given to a baby, infants born or entering RSV season, and potentially a smaller group of infants in that second season who may be still at risk for severe disease, as well as the opportunity for an RSV vaccine to be given during pregnancy in your 32nd to 36th week of pregnancy, if the timing of those weeks coincides with RSV season. But I do want to talk more about the RSV vaccine in our older adults. And so this is from the very hot off the press ACIP recommendations for who in the US should get this vaccine. And so looking at the two available vaccines, we have one from GSK and one from Pfizer. And I have listed here the percentage efficacy in preventing RSV-associated lower respiratory tract disease for both of these vaccines. So 75 to 85% effective here, as well as almost 80% effective in both vaccines for preventing the need for medical attention. So either outpatient or inpatient evaluation for lower respiratory tract disease. And then at the bottom, you can see where I have the relative risk of severe adverse events, thinking about untowed medical events resulting in death or life-threatening conditions, hospitalizations, et cetera, so very low. Severe reactogenicity events, so thinking about more local or systemic reactions to the vaccine, as well as what is frequently talked about, right? The risk of inflammatory neurologic events like Guillain-Barré. And so you can see in both of these for the GSK arm, there were 3 cases out of about almost 18,000 adults. These were all in non-placebo controlled comparator groups. So really unclear if these were would have been seen in the placebo group as well. And then in Pfizer, there are 3 events found in a little less than 20,000 adults. And because there were so few events and no events in the placebo-controlled comparator arm, no relative risk was able to be calculated. These trials were underpowered to estimate the effect or the efficacy against RSV-associated hospitalization and death. But this data, I think, strongly suggests that vaccination may prevent considerable morbidity from RSV disease in our adults older than 60 years old. So the CDC recommends that adults age 60 and older receive a single dose of an RSV vaccine, either of these products, using shared clinical decision-making in order to prevent RSV-associated lower respiratory tract disease. And additionally, what does the CDC say about co-administration of these 3 vaccines? And you can give all 3 at the same time. So save yourself an extra trip. And lastly, I'll spend just a few minutes talking about management strategies for containing outbreaks of these respiratory viruses within healthcare systems or healthcare facilities. And we know very well that any transmissible disease can occur in any healthcare setting. And when you're thinking about contagious disease exposures, it's very important to ask the 5 questions: who, what, when, where, how. So the CDC has 2 great documents, one on testing and management considerations in nursing homes, as well as long-term care facilities, when COVID and influenza viruses are co-circulating, which they are, as well as an additional document on influenza outbreak management in long-term care and post-acute care facilities. And so in any of these facilities, whenever there is one lab-confirmed influenza positive case identified, an outbreak may occur. And then when we identify 2 cases of lab-confirmed influenza within 72 hours of each other on the same unit, outbreak control measures should be implemented as soon as possible. So what are those measures? So we have a nursing home with residents with acute respiratory illnesses. So first and foremost, to start by placing symptomatic residents in transmission-based precautions using all of the recommended PPE. And it's recommended that you start with PPE targeting both influenza and COVID. So that way you cover all of your bases, and then increase your active surveillance, not only for the residents in the facility, but also for the healthcare personnel and visitors. And it's important to remember that symptoms in older adults or those who are medically fragile or in those with neurological, neurocognitive conditions, those people may manifest atypical signs and symptoms for COVID and or flu, may not have fever, may not always manifest more traditional respiratory symptoms. So keeping in mind, surveilling for more subtle symptoms like malaise, headache, dizziness, as well as GI distress. Testing of symptomatic residents for both COVID and flu will be very important. And so because both COVID and flu can co-infect individuals, it's important to remember that a positive influenza test without COVID testing does not exclude COVID, and vice versa. This is a graphic from the Infectious Diseases Society of America looking at how to guide the use of influenza virus diagnostic testing in investigating outbreaks in the institution or other closed settings. So I think it's a great resource to look at, especially if we are starting to think about outbreak management. And then thinking about what types of tests to use. We all are familiar with antigen and nucleic acid testing. If we can use more of the molecular testing, that would be preferred because of the low to moderate sensitivity of antigen detection. And then thinking about placement. So patients who are confirmed to have one of these respiratory infections, important to remember to keep them in a single room if available, or to cohort with others who have the same respiratory virus, and to try not to move them around through the facility. And then clinical management, very important. And I'll talk about most of them in a second, but just also remember that there are other things to consider, like if you cannot isolate, how to transfer a resident to a different facility, placing physical barriers, how to optimize ventilation, filtration, and things like that. So in the setting of a potential outbreak at a long-term care facility, all long-term care facility residents who have confirmed or suspected influenza should receive antiviral treatment immediately. So the key here is not to wait until lab confirmation of influenza. And then it's important to promptly initiate antiviral chemoprophylaxis with oseltamivir to all exposed individuals. And then if you have an outbreak, so those 2 residents ill within the 72-hour period, important to expand chemoprophylaxis to the unit, and then potentially considering expanding that even further to unaffected units or wards, depending on other factors like unavoidable mixing of residents, or if there are healthcare personnel from affected and unaffected units circulating throughout the facility. This is important, the chemoprophylaxis, in order to try and prevent transmission among residents. And then additional measures that are important, staying in the room as much as you can, limiting large number of group activities, working with CMS and the state health department for visitation, as well as monitoring for healthcare personnel absenteeism. And in the last minute, a quick plug for vaccination as a means of prevention. So don't forget to vaccinate if there is an influenza outbreak. Those residents who may be not vaccinated, please vaccinate them. And also think about COVID vaccines, RSV vaccines, and then don't forget our pneumococcal vaccinations as well. And with that, I will finish with 1 or 2 minutes to spare. My email is at the bottom. I'm happy to answer any questions, and I look forward to any questions in the chat. And thank you so much.
Thank you so much, Dr. Fleece. We do have time, hopefully, for 2 questions that came in. One was, should all adults over the age of 60 get the RSV vaccination regardless of their health status, i.e. if they have no health conditions, they don't have diabetes or any heart conditions?
Yeah, I think it depends. And I think that's where that shared decision making comes into play. It's a relatively new vaccine, and whereas all of the data looks very encouraging, and it looks like the adverse events and side effects are going to be very low, like most of our vaccinations are, I think that's where that shared decision-making phrase from the CDC comes into play. So if you were my parent over the age of 60, even without health conditions, I would say I think it's a good idea, because of some other factors, like my parents are around small children who just got over having RSV last week, and I would like to keep them out of the hospital and keep them safe. But I think if you have any particular concerns about yourself or why you would not want to get the vaccine, that's where talking to your healthcare provider would be the best option.
Sounds good. So have that conversation. The last question I think we'll have time for, someone said that there was research that was just announced that indicates a possible connection of increased risk of stroke in patients older than 80 when they get the flu vaccination and the COVID vaccination at the same time. Have you heard about that?
I haven't. I would need to look at the data. I think the risk of stroke in all-comer patients over the age of 80 is going to be higher than those less than 80, and so it might be an artifact in the data. I think if there had been a big signal, we would be seeing a health alert come out, but I will keep my ears to the ground for it, and happy to update the group if anything comes up.
Sounds good. Well, thank you again, Dr. Fleece, for being here, for helping us prepare for this respiratory virus season that we're in right now. We so appreciate your time spent with us this afternoon.
Thank you so much, everyone.
And thank you everyone for attending. We look forward to seeing you back at our next webinar on November 7th. Have a great afternoon.